Good afternoon, everybody, and welcome to Value in Health Week 2023, brought to you by the Welsh Value in Health Centre. This is session 2 of the week and the second session of today, which is why implement PROMs. Our panel, who I'll introduce to you in a second, will discuss this, and then we'll open it up to an audience Q&A as we go along as well. Firstly, just to introduce myself really quickly, my name's Gareth Setter and I'm the Head of Comms and Engagement at the Welsh Value in Health Centre. Apologies, because actually our Deputy Director, Adele Cahill, was supposed to present this session, but isn't available, unfortunately. So in that old saying, you've got me off the substitutes bench at the last minute. Before we get into the session, just a couple of things to quickly tell you about. All our sessions are recorded, so we'll be putting them up on our website as soon as we can. And also on our website, you'll find the timetable for the week ahead and all the links to enable you to join any of the sessions that you would like to join. They're all open, so you don't have to pre-register at this stage or anything. You can just click the link and join the session. So our website is vbhc.nhs.wales, but we'll put a link in the chat for you all to see. The other thing that leads me on to the chat, I suppose, is the question and answer function, which you should see at the top of your screen. That is for you as in the audience, because Teams Live doesn't allow you to have your cameras on or your microphones on. So we really, really want to encourage you to participate in this session and all the sessions. And we really want to put your questions to our panel of experts. So please use that Q&A slot as much as you want. Please use it throughout the whole session. We'll dedicate some time towards the end of the session for question and answers, but pop those questions in whenever you come up with them. We really, really want to hear from you. Right, let's get into this session then. So we're asking why implement PROMs, and our panel are here to give their views on that question this afternoon. What I really like about this panel, we do have one member that we're still trying to get on, the old technology issues occurring to us, but what I really like about this panel is the breadth of experience and the variety of experience that we've got. You know, everyone's worked in the PROMs field in different areas, so I'm hoping over the next hour we'll really be able to untap a lot, or tap into a lot of their knowledge. We want this to be really informal, so we said to the panelists just to jump in if they have something to say. You know, don't wait to be asked at all. We want it to be chatty and really get into the heart of the matter. So let's get straight into the introductions. So first of all, I'd like to introduce you to Melanie Thomas. Mel's the Clinical Director of the Lymphedema Wales Clinical Network, physiotherapist by background. Mel was and is instrumental in setting up equitable lymphedema services in Wales. Mel has published widely and presented internationally, making the Welsh network a credible clinical network worldwide. So embarrassing, Mel, isn't it, when people say those things about you? But thank you for joining us, Mel. It's really great to have you here. I was going to introduce Kathleen with us, but we'll come to that because we're trying to get Kathleen on. So next, I'd like to introduce to you Sarah Puntoni. Sarah is one of our programme managers here at the Welsh Value in Health Centre. Sarah joined the NHS Wales in 2007 and has been the lead on the development and delivery of a number of national projects focused on service improvement, person-centred care, patient experience and health literacy. What it doesn't say in the official bio is that Sarah is one of our go-tos here at the Welsh Value in Health Centre regarding PROMs and PREMs. We'll be like, Sarah, what do you think of this? What do you think of that? What do you think of this? So we thought, well, Sarah's the ideal person to have on the panel so that you can also tap into the knowledge that Sarah has for a wider audience. So thanks, Sarah. Thanks so much for joining us. Right, while we're waiting for Kathleen, we'll jump straight in. And Mel, I'll come to you first, if that's okay. And I know we've just sought biographies, if you like, but can we go back to the beginning and find out how you first got involved in the world of PROMs? How did that come about?
Okay, so for those of you who know me, I'm always trying to get money. and getting money from research or Welsh Government or anywhere I can get money. And over the years, we've collected clinical reported outcome measures. And I've collected qualitative data, quantitative data, health economics I've gone into. And I always remember presenting once and they said, oh, your data is really interesting, but what about patient-reported outcome measures? And it's just that, oh, right, okay, I'll collect patient-reported outcome measures then. And I remember coming back and thinking, right, well, what do they mean? We do EQ 5D, 5L, we look at other quality of life. And we started chatting about, okay, what really matters to patients? And for us to understand what really matters to patients, you've got to talk to patients. It's not clinicians, because we think we know what they want, but actually we have no idea whatsoever. And that's how it started. And I'm going back probably about 2014, 2015. And we were doing a project at the time called lymphatic venous anastomosis, which is a microsurgery technique. And they wanted real outcomes for patients that we could prove it was beneficial or not. And that's when we started talking to patients. And, they came up with things that we had no idea about. Things like how lymphedema impacts your intimacy and desirability, how it impacts your body image, your hobbies, your work, your finances, and for us, the number one patient-reported outcome for measure for us is actually purchasing shoes and clothes. We would never have found that about. So that's where it came from. And then it's just gathered speed.
Yeah. And do you think with those PROMs, so if you take lymphedema and you take that around body image and buying clothes, do you think that that is something that wouldn't come out in a face-to-face consultation? Do you think there's something about patients putting that into a PROM, if that makes sense?
Yeah, I think it's very, very different. We're all patients. And for me going, to an outpatient clinic, when I dislocated my shoulder, they weren't interested in how my shoulder impacted my life. It was very much, you've got full range of movement. What's your pain like? We can't, surgically change it. Just get on with it. And I think that's the difference, because how can we help people if we don't really know what's really important to them? And, as I go back to what I said at the beginning, us as therapists, we are the worst, because, we've got 10 patients, 15 patients. You want to get through your list, so that you've done all the writing, you've written back to whoever you need to write back to and the patient. So you've got a set criteria on your assessment form that you need to meet, but it may have nothing to do with what the patient wants to come and talk to you about. So that's why I think, PROMs are vital, and why we don't always collect what we should be collecting.
Amazing. And then Sarah, we'll come back and talk about that as well, Mel. But Sarah, for you, like if you zoom us back as well, because Mel, 2015, that's what, 8 years? It was very early days of PROMs, wasn't it? So when did you first get involved in PROMs, Sarah?
I think PROMs I used to work for Thousand Lives, or what is now called Improvement Cymru, on the person-centered care team. And PROMs was something that was always discussed, but I always tried to avoid it, to be completely honest, because it felt too big, too difficult to look at it at system level. And then the opportunity came on in 2016 to join the PROMs, and Effectiveness Program, and that gave the opportunity to actually look at it as a full-time position, rather than trying to do 20 things as we quite often try to do in the NHS. But I came to it very much from the person-centered care point of view of, you need a standard way to be able to understand people's goals and what really matters to them. And I think PROMs is that missing link. So we're quite good at collecting all kinds of data in the NHS, but that patient-reported element beyond experience, we haven't really done it. And to me, this was the missing link.
Yeah, so because we had that clinical data, but nobody was asking the patients what they thought.
Yeah, and to be able to do it in a way that is, you can aggregate it, because we can ask goal setting and things like that, and they're very useful in that clinical environment. But then when you try and look at it at the next level of the service or the system, it doesn't quite work. And I think PROMs is the perfect way of getting that voice of the patient throughout.
Yeah, definitely. So Mel, is that how you started in that sort of I know you're still doing that, but did you start in that sort of slightly smaller scale direct care approach to PROMs?
Yeah, again, for me, it was to get money to prove that lymphatic venous anastomosis, the surgery, was actually beneficial to patients. And, when you're talking about super microsurgery, there's a vast range of outcomes, clinical outcomes that could change, such as I don't have any more cellulitis because I've had this super microsurgery technique. But actually, so what did you stop your cellulitis? What else does it affect in your life? And it was that, what next? What else? And that's where it came from. And, when we look back to where we were, I was very much about lymphedema is swelling. So it's legs that are, could be 100% bigger than your other leg. So I was very much volume. Let's reduce that swelling. But actually, people would come in and say, but I'm not really bothered about the swelling. What I want to improve on is that I can get my shoe on. Or what I want to improve on is that I can walk. My mobility is better. My leg doesn't feel heavy. Sometimes volume doesn't change. So we needed something else that we could record that was important to patients, but you could actually then argue to say, this is why it's so important to have lymphedema services, because we are improving, patients can wear shoes, patients can go for a 5-mile walk when previously to our intervention, they could only do 1 mile. And that's gold standard sort of thing.
Yeah.
Most people can't walk to the end of the road. But those are the type of things we really needed to discover. And, as Sarah said, it's great now that we've got this aggregate level, we've got 20-odd thousand PROMs now. So when we say something, we really know that it's scientific, I guess, or, it's not just from like 10 patients. This is from 20,000 patients. So we've got much more evidence to base what we're doing on.
And I suppose, Mel, as well, that takes me on for you, because you've moved those PROMs onto a level now where you are in that service improvement and service planning area, aren't you? Because I know you've recently appointed a clinical psychologist into the service.
Yeah. And, as I said, we would never have had that, in that we knew that lots of our patients suffer with anxiety, depression, mental health issues. And it's always been that, oh yes, so-and-so patient, they've got depression and their lymphedema is really affecting them. But when you start to put all of those comments together, suddenly we had 20% of our caseload, had body image, intimacy, desirability. When they look in the mirror, they look what their swollen arm looks like or their leg looks like. They don't go out of the house. And it builds on to them taking medication, being referred into numerous other services because of lymphedema. But we couldn't get sort of treatment for them. As you're probably well aware, psychologists are very few and far to come by. So we felt, look, the only way that we're going to do this and to really understand is to gather more data, which PROMs enabled us to do. So then we had loads of evidence to say we can sort out the physical side of lymphedema, but the psychological side, the emotional side, we can't help our patients. We can to an extent, but not the level of a psychologist. So not only did we end up with getting the evidence to prove the need for the psychologist, but it's also then working out what the staff, all the other lymphedema colleagues, in Wales, to upskill them so that we can start talking the right words that we should be saying to our patients from a psychological aspect. And, that's where we're currently at. Jane Williams is in post. We've just started getting referrals in. And there's lots and lots of work to do, but we would never, ever have got this without PROMs.
Yeah, that's fascinating, because, I mean, I've been lucky enough to speak to Jane, and it's that parallel approach, isn't it? The patient's outcomes, the patient's needs through those PROMs, but also she's there for your staff as well.
Yeah, definitely. But I guess the big thing for us at the moment as well is understanding what patients want. And we're currently going through a new lymphedema model. And how it used to work is you'd receive a referral, and you would look at what the referrer has said about that patient on the referral form, and you would scan it as urgent, palliative, as in see them, within 2 weeks, urgent within 4 weeks, or routine up to 12 weeks. But we didn't take account of the PROMs, and we didn't actually take account of what the patient felt, as in it's only based on what the referrer says. So what we are currently doing now is we are contacting patients as soon as that referral arrives on our desk. We are getting an administrator to ring them to say, you are going to receive a PROM. It's going to be either on email, it's going to be on your text. You tell us exactly how lymphedema affects your life. With our LymProm, our tool, as well as chatting to the patient to make sure all their details are right. And what we're finding now is our DNA rates are reducing, because the people who really want to attend are attending. Those who think, I haven't got a problem, on their PROMs, they would all be, 1 out of 10, 0 out of 10. Those patients you can solve with a virtual, conversation, rather than dragging into a hospital for an hour face to face. So PROMs can be used in many different ways. It's not only, doing an assessment, it can be triaging patients, as well as SOS. I've got a problem now, I've been PIFU'd, patient-initiated follow-up, discharged from us, but then suddenly they can set off a PROM with us, and then we'll get them back into the system. So there's lots of uses, but it's the patient's voice.
Yeah, it's almost becoming that two-way communication then, isn't it, through the PROM? Yeah, it's great. Yeah, that's really interesting. And Sarah, you've because you've worked in that sort of aggregated PROM, and I know this is probably putting you on the spot, but myself and Sarah have had these discussions about the danger of people seeing PROMs as a survey, as a questionnaire, as an extra add-on. And you always say, Sarah, don't you, that you'd rather people said assessment, so it becomes part of that approach.
That's right. We learned that through the years, really, in that implementation process. If you call it a questionnaire or a survey, it implies that it's more asking for their opinion rather than being part of the clinical pathway. And I think that is where we need to be very clear, not just in the way we talk to the patients about why it's important, but I think the next step is how do we make it visible to the patients, and actually the patient to be more able to actually report, like Mel was saying, their own PROMs when they need to escalate, but also be able to track their own health over time. We're not quite there yet, but I think that's the next level.
The next thing to come.
Yeah.
And Mel, did you find, I suppose, going back into those early days as well, that you really had to engage with patients to explain around PROMs to get them completed?
Definitely, and we're still doing it, and we're still learning what different ways we can do. Only this morning we had a discussion where, we had a patient complaint because they felt it was a scam. And why am I having these emails and these texts off you? But then other times we get patients saying, but I already filled this form in. I've already told you this. Why are you asking me again? And that happens, of course, is when they refer to another service, and then they've also got PROMs. And we do have to be careful, because, there may be a tendency now that everybody wants to do PROMs, that a patient, if they belong to like 4 or 5 services, which lots of our patients are, then they'll end up with 4 or 5 different PROMs. And that can be problematic. So, once we have a new platform, potentially there may be some scope where we, as lymphedema experts, could go in and look at what the recent other PROM was, so we haven't got to ask the same questions. But it can be difficult. But we always tell patients, this is Mel wants you to fill in this form because it's a part of your assessment. We really want to understand, what causes difficulties in your life because of lymphedema. And that's the other thing. It's telling the patient it's related to your lymphedema, or it's related to your heart failure, or your painful hip, or your painful knee. That's the differences that, we try and tell our patients. But the majority of patients, I think they love filling in their PROMs because they suddenly feel somebody wants to know the questions that are important to me.
And then when they filled in their PROMs, and if they need to come in for an appointment, for a consultation, is that something that you show them, get up in front of them, or go through a PROM, or how does it work in that?
Well, it's different in all health boards. We are lucky, you know, we are a national network, and we've got obviously 7 health boards, but 5 of those 7 are using PROMs in a digital way, which is much more simplistic than the paper copies. I'm not saying paper copies are no good. However, there is a tendency of bias. You know, if the patient is waiting for you in the waiting room and they're filling it in, it's very, very rushed. Or if they're filling it in the waiting, actually in the clinical room, and you're hovering around, you know, there is bias. You know, I'm a researcher, you know, there is. So I think we have to be careful of that. During COVID, it went the other way, in that we had keyboard warriors. People were telling us their woes about everything. But there's nothing wrong with that, because it also then opened up other questions to us, as in, you know, we had lots of patients talking about their sleep, and how lymphedema affected their sleep. There's been no research done on this. So PROMs are raising more questions for more answers, I guess. But yeah, you know, it can be, but we do need to get the answers and the right information at the right time.
Yeah, no. I can see some questions coming through, so please, any questions you've got for Mel or Sarah, use the Q&A function at the top of your screen. Will definitely come through to them. Sarah, obviously, we're hearing from Mel with that clinical perspective and all the benefits of PROMs. From an implementation point of view, now, I know what you'll say to me, it's not go to the internet and download a PROM and put it into your service, isn't it? So if I was watching this and I wanted to start implementing PROMs or collecting PROMs in my service, how on earth do I go about it?
That's a very good question. It's quite a big one as well. I think first of all is understanding what you're trying to achieve and really be clear about your aim. Just in the conversation we've had over the last 20 minutes, you know, that you can use PROM in so many different ways. But you almost want to be very clear on what you can achieve and what you do want to do and what is your main driver. Because whether you're doing it at patient level, so for example, to support your validation of your waiting list, or whether you're doing it to support shared decision making within that consultation, or whether you just want to do a cost effectiveness, for example, or just effectiveness of your treatment, that kind of informs the way you're going to roll it out. I think in Wales, we're very lucky. We got, you know, 46, I think, nationally agreed pathway. So chances are somebody, you know, is doing something around PROMs, so they probably have somebody you can go and ask. But also, obviously, we're lucky we got the Welsh Region Health Centre. Granted, I would say that we're lucky, but, you know, we are a national resource and we are there to support everybody. You know, we can do all kinds of search on available sort of tools that are out there that are licensed, perhaps in development, see what the publications and the literature tells us and what would be best to use. So there is a lot of support out there, but I think first of all, you need to understand why you're doing it. If you just want to do it because you've heard about it and, you know, there seems to be a bit of a system push to have PROMs, I think that in itself won't work. You need to be really dedicated. You need to understand your drivers, and you can't do it in isolation, I'm afraid. You might be able to do pen and paper. That is fine. It's a good place to start, and I think we've all probably started there at some point. But it's how do you then upscale it, and how do you try and get that pathway view? And that is where you need more than one person. You need your IT, ideally your value-based healthcare team. You need your MDT approach to the care as well. You probably want some patient reps to help you advise throughout that conversation. So it's very much a team approach, I would say, but there is a lot of resource nationally and locally to support anybody starting on this.
Would you say, Sarah, that when you know what you want to achieve, is it too over the top to say you're entering into a bit of a cultural change, really, because it is going to be into your service?
I think it's a service change, and any service change is a cultural change. You know, you can't say that anything else. You will change the service because you need to embed it into that pathway. That's what we were saying earlier on, isn't it? You need to integrate it into what you do. If you do it as a side exercise, it's never going to work. It's not going to be sustainable. It's not going to last, and it's going to be reliant on individual rather than actually be self-sustaining. So yeah, I think so.
Mm. And Mel, did you? We said about patience, but did you have to sell? It's the wrong word, but did you have to sit your teams down and say, right, this is what we're going to do, and this is why?
Oh, definitely. And I think, you know, I'm going to share with you some difficulties we are having at the moment with PROMs, in that, yes, we've got 20,000 PROMs in from different patients. However, we haven't got the staff now to help the patients who are actually filling in the PROMs. And I'll give you an example. So since the economic crisis, lots of our patients are saying they've got finance difficulties. Now, I'm a physiotherapist by background. I don't know much about finance, but I know somebody who could, and I can signpost patients. And I know certain areas where we can signpost, but I don't know everywhere in Wales. And that's causing some difficulties where staff are now saying patients are filling in their PROMs, they're putting in high scores, and I haven't got the skills to deal with what they're asking me. So we are currently doing another piece of work whereby, you know, okay, what can we do about it? So we're looking at citizens' advice. We've got in touch with, you know, the Department of Health. You know, what benefits are patients allowed to claim? Could they claim? So, you know, what you start off on doing sometimes isn't what you end up on doing. And it's because of PROMs. And again, it's not only finances. That's just one example. Holidays is another one. You know, we say, how does lymphedema affect your holidays? And people are coming back and saying, it really affects it because I can't get insurance. And now suddenly you become experts on, you know, holiday insurance, which has got nothing to do with their lymphedema, but it's actually so important to them that they want to go to Australia to see their grandchild. And then, you know, as I said, it's getting this information to signpost, and that's so important to our patients. So we are doing a piece of work now. We're going to be doing some focus groups with the lymphedema staff to understand what are the difficulties that our staff are facing and what can we do to help them? What information, what courses or knowledge can we, you know, support them with to support our patients?
Yeah, because it becomes so much wider then, doesn't it?
It does.
Than their healthcare delivery.
Yeah.
That's
Yeah.
really interesting. Sarah, I'm going to ask you, because I've seen that Sarah Lawrence has put a question in, and I think it's probably one for you, Sarah, I hope. And please do put any questions that you've got for Mel and Sarah into the question and answer session, and we'll come to them. So Sarah Lawrence says, how would you advise teams on the approach to governance around the collection and utilisation of PROM data? It's not about ticking a box, it's about making sure the data is translated into information and actioned.
Yeah, so governance always comes around, doesn't it? No matter what you do in the NHS, it's always a question. And it's interesting because each health board's got slightly different views on what you can and can't do, which always boggles me, to be honest. I think, again, this is where your local value-based healthcare team is probably best to advise you, because to a certain degree, there will be relevance to your own setup and your own environment in which you work. But generally speaking, again, it goes back to that assessment of PROMs. You know, PROMs is part of your clinical data, and therefore is different than other things such as your PREMs or your survey that you may do to you know, as a one-off exercise, or even if you do PREMs as a regular day. But this is part of your clinical assessment. So from a governance point of view or information and point of view, there isn't really a great deal of issues, if you want, legally wise. There might be in the setup and the implementation element, and this is where your value-based healthcare team is there to advise you. Again, nationally, we can provide quite a lot of help, but there are still some blockages within the system to be able to flow that data. So you might be able to collect it digitally, for example, because you're lucky enough to have a platform. But then to get that data visible to the right people at the right time is not always possible. I think we're moving towards it. And I think it is within reach, or will be within reach very soon. I think there's a session coming up later in the week with Dr. Said Shady, and he'll describe some of that work going on nationally. But I think is like any service improvement or service change you do, is step by step by step, and keeping your eyes on the ball and what you're trying to achieve, but don't try and do everything at once. Start small, test it, improve it, and keep an eye on what you can and can't achieve, and bring other people with you.
Yeah, great, thank you. And we'll come to some more questions, I promise. If we were thinking like sort of the value-based healthcare and PROMs and the connection, how if I come to you first, Mel, how important do you think PROMs are in supporting an approach to value-based healthcare? Sometimes I think, this is probably me being naive, but sometimes I think, do people think value-based healthcare is PROMs and vice versa? Do you know what I mean?
Yeah, I do. It's a part of it, but it's not all about PROMs, you know. Yeah, PROMs help because you're understanding what's really important to that patient, but they need guidance so that you're on a shared decision-making journey together. The PROMs are meant to inform the clinician, but likewise, the clinician helps to support the patient's views as well, you know, in that, okay, you know, this is the evidence. Look, I know you've gone on Google, you want to have this liposuction surgery, we're talking of, you know, for lymphedema, but actually the evidence isn't great, it isn't available. So it's talking about what are the outcomes for the patient, what would be great for them, what would be the cost, but also what's the reality, i.e., okay, if you have liposuction, well, then you're going to have to wear compression 24/7 for the rest of your life. Have you thought about that? You know, so it's having the lots of the, I suppose, what's valuable to the patient, but then also what's it like in the real world, if that makes sense.
Yeah.
So
no,
PROMs are important, but I think we also must remember how they integrate with the CROMs. And that's something that's lacking at the moment, how PROMs and CROMs should be linked together. We haven't got a digital system that does that for us. And, you know, I know a lot of my PROM scores are high, maybe when that patient has a BMI of 50. And, you know, that's what's lacking, I think, sometimes how we can't intermingle the information.
Put all that data together.
Yeah.
Yeah. Something you know about, Sarah, isn't it? But same question to you, Sarah, with that, you know, how important do you think PROMs are in supporting an approach to value-based healthcare?
I think PROMs are quite often, like you say, some people get mistaken thinking that value-based healthcare is about PROMs. And that is, I think, it's because PROMs are the new kid on the block. They're relatively new. We're not, you know, we'd only been talking about them for a few years, really. And certainly within the clinical area, rather than for research and development, which perhaps is, you know, it goes back far longer than that. And I think that's why sometimes the emphasis is on PROMs rather than everything else. But really, it's about being data informed, and PROMs is one slice of the cake, but there's everything else, like Mel was saying. I think the difficulty sometimes is the fact that we are collecting clinical outcomes data, for example, but it sits in audits, it sits over there. We are collecting activity data, and that tends to be more reported, but even that we don't have a full picture. You know, you don't have the full pathway. You don't see primary care, community care, secondary care within one area. So I think that's why sometimes the focus is on PROM, because it's new and we're learning to collect it. But at the other data sources, it's more around accessibility of what's already there.
Yeah. And
is that, sorry, can I just also add as well, it's the PREM data as well. You know, we are desperate. If we could triangulate that data, it would give us much more answers than we've currently got. And, you know, because they're all individual, you get PREM information in and the patients had a really bad journey. Then you've got to pick up their PROMs so you understand, oh, okay, this is going on clinically. Then you've got to, if you're lucky, you get the PROMs. And then suddenly when all three come together, you understand why the PREM is saying what they're saying. But we're not there yet. And that's the difficulty.
Yeah. We see example as well, Matt, just to grow on that, where people are using the PREM alongside the PROM, almost like a proxy measure. So people might report, for example, that they've had, you know, good outcome, they're happy with their outcomes, however, their experience isn't great. That is almost like a ringing bell or saying, well, bring them back because something isn't quite right. And there's learning there to be had.
Okay, great. We'll take some questions from the audience as well. Thanks for these questions coming in. We really appreciate it. So Jessica says, with time being the main limitation during assessments and clinics, did you find there was any resistance to implementing PROMs from staff, or does it go back to how you integrate it, make it part of the assessment? I suppose that's a really good point, isn't it? Because with everything going on, all the pressures that a lot of services are experiencing, is there a danger, Mel, that if you start bring PROMs into your service, you can see as if that's adding extra time, for example, or an extra thing for your teams to do?
Yeah, I mean, that's why digital, it has to be digital if it can be, because what we tend to do, we look at the PROMs before the patients come in, and we have half an hour in the morning. You can quickly look at, oh gosh, that's a bit different to where it was. So you've got that in your head. But it works the other way as well. So once you've got some PROM scores in and they're really low, you know straight away you're going to discharge that patient because they've got no real worries with regards to their lymphedema. So why are they coming to the hospital? So that's when you're going to be pithoing these patients and look, you're managing fine. If you need us, initiate a PROM or just ring us up and we'll get you back in. And patients are in control then to know what they want to do. So it takes a lot of persuasion. You have to sell it to your staff as well as selling it to patients. But once they get it, and they see the outcome as in, you know, oh gosh, I get it now. Why are we wasting patients' journeys in time and energy, taking time off work, when actually they didn't need to come and see me? So it is persuasion, but selling out the good things.
Yeah, so marking those big moments and going and showing your teams what's happening. So do you agree?
Completely, and I think I would add to that as well, is that it's very difficult for anyone to argue against optimizing outcomes. I think is what everybody wants to do. And really, this is just another tools to help you do that. Your first question at the beginning of the session was what got me into PROMs, if you want. I was coming from bringing together shared decision making and motivational interviewing techniques to support, making the best of those 10 minutes if you want in a consultation. And to me, this is the bit that was missing, a way in which you could actually start a conversation that you're already pre-informed. And obviously, the PROMs will only capture so much of that matters, what matters to patient. And, not all PROMs are equally good, I would say as well. Some I come very much from the research arena, and when you put them in practice, don't quite work. So that's another thing that perhaps needs to change as we move. I think this is where those 10 minutes can be really focused, really patient-centered, and this is where the PROMs help. But completely agree with Mel, we need to have that digitally so people complete them in the comfort of their own home when they're not stressed by the clinical environment and they've had time to think about it. But this is why we need to make that PROM visible to the clinicians and the patients. Otherwise, it doesn't really work.
Yeah, that's a really
And
good point.
it's also, if that patient has bothered to fill in that PROM, that when they turn up in that clinic, that those clinicians then ask them about the PROM. We get lots of patients saying, the clinician, I filled them all in, I spent ages filling them in, and my clinician didn't even mention them. And that comes through our patient advisory group. So although we're doing great things, not all staff are. So then it's taking it back to say, look, it's really important to them because they've spent time to fill it in. You need to spend 5-10 minutes to go through it with them.
Yeah, completely.
So,
yeah, because that is not going to help, is it, if a patient's filling that in and then it's not brought up and stuff. Okay. Sarah, I'm going to put this one to you. Please don't think I'm putting you on the spot. So tell me if it's not something that you think is right for you. But Graham Hunter has left a message saying, do you have any suggestions on where we could start looking for information on PROMs usage relating to general practice? I'm conscious that GPs are generalists, so therefore the breadth of patient inquiries is huge. And I put that to you because, one, I thought you might know the answer. And two, obviously, the population survey OECD Paris work that we've been doing, it gives us an opportunity to talk about that as well.
Yeah, so two elements to that, you're absolutely right. One is we've seen quite a lot of movement now within sort of community and primary care. I think it's not that people weren't interested before, but I think it's becoming easier to connect the dots. And I know I'm supporting a couple of services now that in that infrastructure between primary and secondary and sort of community care. And the conversation there is exactly what you just highlighted is when you have so much of a breadth of needs, how do you really focus on what to collect? And I don't think we necessarily got it right, but I think the generic quality of life kind of tools are probably the best ones to go with, because you're looking at that more holistic approach to that person. You look at the quality of life, and then once you assess what their needs might be, then you can focus a little bit more. But I think something like the EQ5D, for example, is a good place to start. And yes, it might not be as sensitive as a limb PROM for lymphedema patients, but it's sensitive enough that you will be able to pick up changes over time. And again, it goes back to what matters to the patient is is short and easy, but yet sensitive enough that will give you a rounded view of your patients. From a data point of view as well, like you mentioned, the OECD Paris is our population surveys that Wales are just taking part in, and we got over 30,000 responses from across Wales, and that is targeting adult over 45 with a chronic condition, although some of them will not have, so it's really a needs assessment for our adult population in primary care. We're hoping to get the data within the next couple of weeks, and that is going to be a gold mine, I think.
And that's a huge amount, isn't it? 30,000.
Yeah.
Absolutely huge, rich data.
Yeah, absolutely.
There's another question as well from Sarah, who might have been one more for Kathleen, but Sarah, I'll put it to you as well. Is there a repository of SOP examples that could be available to teams to reference during scoping?
Example of what? Sorry, I didn't catch the...
Is there a repository of SOP examples that could be available to teams to reference during scoping? So I guess if you were looking initially for the PROMs that are out there, etc.
Yeah, so there's a number of different repository, if you want, and almost like libraries of PROMs. Most of them you have to pay for them, so there's a little a cost. What I would say, if you're interested, drop an email to the Welsh Valiant Health Centre. We can do a scoping for you and see what is out there, potentially giving you some recommendation as well. And I always say as well, if you can, touch base with your colleagues around Wales, because if you're thinking about doing PROMs, chances are somebody else is as well within your clinical areas. Don't do it in isolation. Bring everybody with you, because it really is a team sport. You need as much support as you can. But nationally, we can definitely look for what tools are out there for you. We just need to know what your clinical areas or population you're interested in looking at.
Yeah, great. And like we say, please feel free to put any questions that you've got for Mel or Sarah in the Q&A section. Mel, we're coming to the end of 2023. What's next for you in the world of? I know you've got loads going on in the set, but what's next for you in the world of PROMs?
So I guess we were slightly different in that although we did the EQ5D5L, which is a validated tool, we felt that it wasn't sensitive enough for lymphedema, which is why we created LymPROM. We've done lots of introductory papers, and our final validation paper is going out any day. So LymPROM will be finally validated. So what I guess I wanted to say is, yes, use something that's there, because that makes life so much easier if it's a validated tool. But if there isn't, and if there is nothing internationally that you can't use, don't be put off from creating your own. Yes, it does take time, but Value in Health and researchers will support you along the way, and I think that's important. So what else are we doing? We have created CelluPROM, following on the PROM field. So we got LymPROM, CelluPROM. Now, CelluPROM is cellulitis, which is a skin infection. It affects thousands and thousands of people internationally, and there wasn't a cellulitis PROM. So one has been created, and again, it's going through validation. And I think we're up to about nearly 4,500 PROMs in CelluPROM as well. So that's ongoing. And then our children, currently the tools that we've got aren't suitable for children. So we're looking at a child's version of LymPROM. And then lastly, we're looking at PROMs. So those are your family reported outcome measures. And there's quite a bit of work going on in the background as to, especially with the children, how do their parents cope with having a child? How does it affect, their lives having a child with lymphedema? So that piece of work is going on. So still lots and lots happening with us.
Yeah, so busy 2024. So we'll book you in now for next year's Value in Health week, if that's okay. Sarah, what is the 2024 dream for PROMs for us as a national programme?
I think is getting those PSOM compliant platform out and embedded into the system, and see that data visualized both at personal level, individual level within the patient electronic records, but also within dashboard, and start making that data much more visible, much more usable for everybody involved. I think it is within reach now. We're really close, and I think it'll be, it's been a long time coming. Some of us has been at it for years, And it's really quite exciting. I know that data standards are, tend to be a dry subject, I would say. But actually, it makes such a difference to know that once these platforms are going to be available and rolled out, it's going to be much more easy for anybody like Mel, for example, that wants to go live with a PROM to be able to do so and know that you don't have to wait 6 months, 18 months to be able to see your own data, but actually will be there, will be accessible, and not just to you, but your colleagues as well. And I think that's really quite exciting. So for anybody interested in, again, the session on Peace on Digital, I very much recommend that.
Which is tomorrow afternoon, actually. So this time tomorrow, 2 till 3, our Chief Digital Officer Said Shad, you'd be talking Peace on, and we'll go through all that with you. I won't be on that one, thankfully, because that would be right over. But he'll be able to explain it really, really well. Sarah, if somebody said, okay, give me one piece of advice, one main consideration if I wanted to implement PROMs into my service, what would it be? Just one that you have to push everything else to one side.
Gosh. I'm kind of swinging between two. Can I have two?
I'll give you two. Being as it's you, I'll give you two.
I think one would be, don't aim for perfection. Just start going and work at it. Perfection doesn't exist in this world, and there's no point in striving for it. I think is go with what you got and grow with it. And the next one would be know what you're trying to achieve, because actually you can't do everything. And unless you're really clear on what it is that you're trying to get out of it, it becomes really messy, then the implementation and the using of the data. And then you might work out that you worked at it for 6 months and what you get is not what you need because you haven't been clear at the beginning of what it is that you want.
It's interesting. And same question to you, Mel, on the spot, I know.
Mine's probably quite easy. Mine would be, you've got value-based healthcare staff in your health boards, and you've got the Value in Health team. They are a huge resource with lots of information, so use them. So whatever ideas you've got, take them, your idea, tell them how you think it will work, and go for it.
I like it. It's brilliant. But the question is, could it be possible to do PROMs on telehealth services? Do you have anything available in that area? And could you help with the scoping on the topic?
Yeah, definitely. So our Celu PROM is done all virtual. So
right, okay.
That's how it works. So the patients receive it and they only get a virtual pre-assessment, we call it. Because if you call it a virtual whatever, patients don't understand what you mean. But if you say it's a pre-assessment, they understand what that is. So definitely we've done it and it works because, although we're based in Cymru, we are seeing patients across the whole of Wales. So definitely can work.
Sarah?
I completely agree. Yeah, there's no reason why you wouldn't. It's an assessment and you can roll it out and embed it to any kind of service, whether it's digital or face-to-face. It's the practicalities of it and goes back to what are you trying to achieve to get you help select what it is that the best tool to assess what you're trying to do. Again, probably EQ5D might be quite sensitive, but you probably want something a little bit more. What we've done in some cases as well, you get a validated set like the EQ5D or the Lean PROM, but say that it's not quite all that you need. You could add additional questions to it. So again, sometimes that is a nice way to go around something like that, or even where there might not be the perfect tool available. If you find something that meets 80% of your needs, you can tap the 20 with just additional questions.
Yeah, okay. And we've got a few more minutes to go, so if you want to get any questions into us, like I say, I use the Q&A function. I missed some out, I apologise. Ojo says, how can transparency and shared decision making be achieved while communicating PROMs findings to patients? Mel?
I think we've just got to be honest. Once you've got that PROM in front of you, whether it's on the screen or whether it's on a paper copy and the patient's with you, then you go through it. And as I said to you earlier, you know, some patients are coming in, they've looked online, they want liposuction, but liposuction isn't available on the NHS. So it is that being honest that it isn't available, but what else can we do together that could possibly help you? I think it's just being as honest as we can be, but taking into account what that patient is writing down on their prom and talking it through.
Yeah, okay. And on that note, where are we, would you both say, with patient being able to visualize their own PROMs? Like, do you actually show them something on a screen, Mel, or, you know, what stage are we at that?
Yeah, you can. Again, it's different in every health board based on, you know, IT and digital, what's available to you. But I think it is important that patients see what they have written and possibly, look, this has changed. You know, last time you said your problems of pain was 9 out of 10. You've actually scored that now as 6 out of 10. And then it's, yeah, well, it is better because I'm sleeping better. You know, I haven't got to take as many painkillers. So, you know, having that available to you, it does help the consultation.
Yeah, because they could actually see that on a screen where it's going down, and then realize what they said. Sarah, it's something that the team are looking at, isn't it? The national program is that PROMs visualization.
Yeah, so
from
we
a
have
patient point of view.
Sorry, yeah, we have 3 already visualized within the WCP or the patient electronic platform, which again, not everybody uses, but it is used in the majority of health boards and majority of services. And that is a good start. Obviously, again, the more data we have, the more we can visualize it and make it accessible to everyone. I think to me, just seeing it with the clinician is still a bit of a paternalistic approach to care. Like Mel was saying, ideally, you want to be able to give access outside that clinical environment. You know, people these days, I track my steps every day and I'm rubbish at it, but I only know rubbish because I can track it. And again, I want to be able to do that for my health, and PROMs should be one way of doing it. Now, the NHS app that is now finally live and being rolled out, I think that's going to, again, help us get to that stage.
Yeah, and as a clinician, Mel, do you think the NHS app will enable that two-way communication a lot more?
I hope so. I hope so. You know, it's very difficult when you've got so many patients in clinic that you've got to see. And if the technology works, then that's amazing. But, you know, we are dealing with, you know, thousands and thousands of people on the same internet, and things break down, as we know. So we need a backup, is what I'm probably trying to say. The iPads I found very useful. Have to say, showing patients things on iPads in that clinical room, that works because it's there and then, and it's mobile. And but again, you're reliant on good connectivity.
Yeah, because we are used in other forms of life, aren't we, into being able to see our own data that we've put or following journeys and so on. Yeah, okay, that's great. Okay, well, listen, both, thank you.
Can I just add to it?
Go on.
Because I think just another thought from it. I think the pandemic has, if anything, helps in that respect. I think we all got a lot more used to hearing about health data, for bad or for worse, but it becomes much more mainstream, and people are more used to it. People are more used to talking about health data and tracking health data. So I think we need to actually grow from that and really make the best use for it. You know, the young kids or young adults, they're already doing that with their own health, and you know, we need to embrace that and really push it forward.
Yeah, okay. Before I finish, do either of you have anything else to add, or?
No, I think don't be afraid of PROMs. You know, if you're just starting out and you'd like to have a go. See what you can gather. There are lots out there. It's much easier to do a validated tool, but if there isn't one, don't be put off, is all I can say. And, you know, if anybody wants further information of what we've done, I am on the global
Really appreciate it. Really appreciate your time. Really appreciate hearing about your stories and experience. It's been really great. So thank you so much for taking part. This session, you know, it's automatically recorded. So like I said at the start, we'll get it up on our website as soon as we can. And our next session is tomorrow now at 10:30 to 11:30, which is also a panel chaired by Sally Lewis, which is defining value-based healthcare. What does it mean to you? So Mel, Sarah, really appreciate it. Thank you everybody for joining us, and we'll see you all soon. Thank you.
Thank you.